central nervous system pathology. And as always, the first topic is about relevant anatomy and a bit of physiology, so that pathology understanding would be very easy for you. Okay, now look at the sagittal section of the brain. Okay, this is a medial view. There are so many structures of our central nervous system there. Okay, I'm sure you have already learned this in anatomy. This is called cerebrum. Okay, cerebrum. This is a frontal aspect. So this is a frontal lobe. This has to be the parietal lobe right there. Okay, temporal lobe is difficult to see here. Okay, this is on the other side, but the medial view can be seen somewhere here. And this is the occipital lobe. This structure is called corpus callosum. Corpus callosum. It's a bundle of white matter which connects to cerebral hemisphere. Okay. Now this area, look at very carefully. This area is thalamus. Okay. Thalamus is called relay center of the brain. Okay. Then this area is hypothalamus. Here is the pituitary gland. Okay. Sorry, this is optic chiasma, and here is the pituitary gland. Optic chiasma is right above the pituitary gland. Okay, this is pituitary gland. This is optic chiasma. Now, what are the other parts of the brain? Here is the midbrain. This small area is called midbrain. This bulge area is called pons, and this is medulla. So midbrain, pons, and medulla. And medulla will continue as spinal cord. This is spinal cord. So this structure is called foramen magnum of our skull. Okay, this is cerebellum. This structure is called cerebellum. Okay, now this is sphenoid sinus. Sphenoid sinus. Here is the frontal sinus. This is nasal cavity. Okay, so these are some of the important structures of the brain and related areas. Now, another important anatomy here are the folds of dura mater. Now see that this is again a sagittal section where brain has been removed. Only meninges fold are there along with the skull. Now see this white structure here. Okay. This is the fold of dura mater. Okay, this is the fold of dura mater. This is called falx cerebri. Okay. Falx cerebri. Now this is a tent-like structure which separate supratentorial compartment of the cranial cavity from infratentorial compartment. So this is tentorium cerebelli. Tentorium cerebelli. So two folds we have discussed. Falx cerebri, okay, the sickle-shaped structure, falx cerebri, and here is tentorium cerebelli. Now, two other folds of dura mater are also there, which are relatively more important than other. One fold is between the lobes of cerebellum. This is called falx cerebelli. Falx cerebelli, and the last one is called diaphragma celli. Now, diaphragma celli is right here above the pituitary gland. So let me revise again those four things. Falx cerebri, right here. Falx cerebri, tentorium cerebelli, okay, falx cerebelli, which cannot be seen here because it's present in between the lobes of cerebellum, and diaphragma celli is present here. Now, a little bit more things. You can see these blue lines here. These blue lines are the veins. Okay, these are called dural venous sinuses, and dura mater contribute for the formation of dural venous sinuses as well. These are called cerebral veins. Okay, all of these cerebral veins ultimately drain into the sigmoid sinus, and then sigmoid sinus will continue as internal jugular vein. Now, another very important structure or anatomy as well as a bit of physiology I like to highlight is the ventricular system. Ventricular system of the brain. Now see here, this ventricular system. So this is our brain. Okay, and here are the ventricles. These are the lateral ventricles. Lateral ventricles. These are the horns of lateral ventricle, and this is third ventricle. Third ventricle. Here is the fourth ventricle. So two lateral ventricles, one third ventricle, and one fourth ventricle. Okay. Now let me talk something more. CSF is mainly present, mainly secreted, okay, or produced by lateral ventricles. From lateral ventricle through foramina of Monro. Foramen of Monro, we say actually, because it's a one foramen, so we say foramen. Foramen of Monro, CSF will drain into the third ventricle. Third ventricle is right here. From third ventricle, CSF will flow into the fourth ventricle through cerebral aqueduct of Sylvius. Okay, this is cerebral aqueduct of Sylvius. And from fourth ventricle, there are three openings now. One is the median opening or median aperture. This is called foramen of Magendie, and two are on the lateral side. They are called foramen of Lusca. Foramen of Magendie is median one, foramen of Lusca are lateral one. And through these openings, CSF will enter into the subarachnoid space, and it will circulate all around the brain, and it will circulate around the spinal cord as well. Now, all the concept which I just described is very nicely explained here. Okay, this is another sagittal section. See here. Okay, so here is the lateral ventricle for you. So lateral ventricle is the main area which secretes CSF. From the lateral ventricle, it will go to third ventricle through foramen of Monro. Foramen of Monro. This is third ventricle. From third ventricle, it will reach the fourth ventricle through cerebral aqueduct, a very small, okay, duct here. This is fourth ventricle. From fourth ventricle, the CSF will come out into the subarachnoid space through three openings. One foramen of Magendie, which is a median one, and two Lusca, which are the lateral one. And then CSF will circulate all around the subarachnoid space. See there, this is subarachnoid space. It is also present around the spinal cord. Okay. There is a central canal of spinal cord which also has CSF, and this has a direct connection with the fourth ventricle. Now, one more aspect here, where the CSF is absorbed. This CSF is absorbed in the superior sagittal sinus, okay, through arachnoid granulation and arachnoid villi. Okay, arachnoid granulations and arachnoid villi, they will help the absorption of CSF, and it will ultimately go into the superior sagittal sinus. Now, this is a frontal section of that absorbed area of the CSF or absorption area of the CSF. See here, these are the arachnoid granulation, and they will help CSF to enter into the superior sagittal sinus. Now, this is our brain. Okay, this is our brain, and this is a frontal lobe of the brain. Okay, frontal lobe. This blue color. This green color is the parietal lobe. Parietal lobe. Okay, this color here is the temporal lobe, and this color here is the occipital lobe. So frontal lobe, parietal lobe, temporal lobe, and occipital lobe. And here is the cerebellum. Cerebellum, and this is the midbrain along with the brainstem. Okay. Now, this is the central sulcus. Okay, central sulcus. This central sulcus is the boundary between frontal lobe and parietal lobe, and this central sulcus is a very important landmark here. Okay, anterior to the central sulcus is the primary motor cortex, and posterior to the central sulcus is primary sensory cortex. This area is sensory, this area is motor. This is sylvian or lateral fissure. Okay, this is an important fissure which divides temporal lobe of the brain from parietal and frontal lobe. Transverse fissure, this is transverse fissure, okay, between cerebellum and occipital or the temporal lobe. And this is a longitudinal fissure which is present right between the two cerebral hemisphere. In other words, I can also say it is present between the two parietal lobe. Now, another important concept is blood supply of the brain. Now, let's go back to your anatomy again. You have already done this before. So, which are those arteries which take blood to the brain? Okay. There are two internal carotid arteries, okay, on either side, and two vertebral arteries on the either side. Now, internal carotid artery is a branch of common carotid artery, and common carotid artery comes from the arch of aorta. Okay, we have left common carotid artery and right common carotid artery. So naturally, we have two internal carotid arteries on either side, and we have two vertebral arteries as well. Now, which big artery gives rise to the vertebral artery? This is subclavian artery. First part of subclavian artery gives rise to vertebral artery. Now they go higher up towards the cranial cavity. Now, what happens when they enter into the cranial cavity now? Okay. Now look at this picture here. This is the common carotid artery. It has divided into external carotid. Okay, this is external carotid and this is internal carotid. And this is the vertebral artery. See here, it is going up from the transverse process of cervical vertebra. This is a very important landmark. There is an opening in the transverse process of the cervical vertebra, and through that opening, the vertebral artery is going up towards the cranial cavity. Now, when it reaches at the base of the brain, when it reaches at the base of the brain, the two vertebral arteries will combine together and form a basilar artery. It will form the basilar artery, and this basilar artery will ultimately divide into two terminal branches which are called posterior cerebral artery. In between, it will give blood supply to so many structures which are present there. Okay. Now, two internal carotid arteries also go into the cranial cavity, and then they will also divide into so many branches like anterior cerebral artery, okay, middle cerebral artery, okay, middle cerebral artery, right? This is middle cerebral, this is anterior cerebral, and this is anterior choroidal artery. See here, okay, you can see anterior choroidal artery, okay. This is called posterior communicating artery, posterior communicating, which is going and communicating with the posterior cerebral artery here. And there is a small anterior communicating artery as well, which is connecting to anterior cerebral artery. So it is forming one circle-like structure here. Now let's trace this dotted area here. Okay, this dotted structure or area which looks like a circle. Okay, and it is made by anterior communicating artery here, okay, anterior cerebral artery, okay, internal carotid artery right here, posterior communicating arteries right here, and posterior cerebral artery with basilar artery, small part of basilar artery as well. This is called circle of Willis, and this circle of Willis is the network of anastomosis of different blood vessels in the basal surface of the brain, and the function of this is to supply blood to the different parts of the brain. Please revise this from the anatomy book and make sure you know every bit of this, because this is very, very important anatomy. Okay, the same thing it's shown here. Okay, this picture is taken from your Netter Atlas. See here, these are the two vertebral arteries combined together to form one big basilar artery. It is divided into posterior cerebral artery. In between, it has given many different branches. Okay, now two internal carotid arteries on either side. Okay, it has also given many branches. This is anterior cerebral artery, which is going anteriorly, of course. This is middle cerebral artery, which is going towards the lateral side. And this is called posterior communicating artery, which is connected with the posterior cerebral artery. And there is a small anterior communicating artery, which is connecting to anterior cerebral. So this is the circle-like structures. Okay, I already talked about the component. This circle of Willis gives rise to two sets of branches. One set goes very deep. These are called penetrating arteries. Okay, and another set goes very superficial. These are called superficial or cortical branches. So penetrating branches and cortical branches. So that's how it give blood supply to the different parts of the brain. Now, where this anterior cerebral artery goes and what are the supply area of this? See here. Okay, see here. This is the anterior cerebral artery for us. This one. So it is going mainly towards the medial surface of the brain. Okay, medial surface of the brain, and it is in very close contact with corpus callosum. It will give many branches, and it mainly supplies the medial surface of the brain. Okay, now what about the middle cerebral artery? Now this middle cerebral artery goes towards the superolateral side. Superolateral side, and this is out of those three important branches. Okay, namely anterior cerebral, middle cerebral, and posterior cerebral. This is the most important branch. Okay, because it supplies many important areas of our brain. I am talking about higher center. Okay, this is middle cerebral artery. Now this diagram, okay, looks very simple, but it carries a lot of meaning here. Okay, see this, there's a small strip, okay, on the superolateral surface is supplied by anterior cerebral artery. Okay, this whole area on the superolateral aspect is supplied by middle cerebral artery, and this yellow area is by posterior cerebral artery. This is the occipital lobe. Okay, and this is the temporal one. So most of the occipital lobe and a bit of the temporal lobe is supplied by posterior cerebral artery. Okay, a small strip on the superolateral surface is supplied by anterior cerebral artery. Okay, at the superior most area, and most of the other area is by middle cerebral artery. Now we are looking from the medial surface of the brain now. From the medial surface, most of the area is supplied by anterior cerebral artery. There's no doubt about it. Small part of the temporal lobe by middle cerebral, and all posterior aspect and inferior aspect by posterior cerebral artery. Now this is the inferior surface of the cerebral hemisphere. Okay, so all three arteries have shared the areas here. Anterior cerebral, okay, again towards the medial aspect, lateral aspect by middle cerebral, and posterior aspect by posterior cerebral artery. So please revise this many times. After doing this important anatomical discussion, let's enter into the pathology now. We'll talk about edema, that is cerebral edema, cerebral herniation, and hydrocephalus. All of them are important terminology. Edema, what is the basic meaning of edema? Every pathology student know this. Edema is, okay, collection of extracellular fluid. We are talking about central nervous system now. So in between the neuron, if there is collection of free fluid, we call that edema. And our brain doesn't have any unnecessary free area there. So if there is excessive collection of the fluid inside the brain or even in the spinal cord, okay, it will get compressed by the rigid skull or the vertebral areas. The skull provides very little room for brain parenchymal expansion in disease state. So if there is cerebral edema, our brain will be compressed and quickly can develop raise ICP. Okay, so in this topic we'll talk about different aspects. Now, cerebral edema is the accumulation of excessive fluid within the brain parenchyma. There are two types of cerebral edema, and they are called vasogenic edema and cytotoxic edema. Vasogenic edema and cytotoxic edema. Now, there is a difference between this term. Vasogenic edema occurs when blood-brain barrier is disrupted, allowing capillary leakage, okay, into the extracellular space. So when blood-brain barrier is disrupted, this will allow fluid leakage from the vascular compartment, that is from the capillaries, into the extracellular space, which results in edema. Okay, so this can be either localized means in some specific areas, or generalized means whole brain may also be affected. Let's give one important example here. Okay, inflammation of the brain. In one particular area, inflammation may occur, like brain abscess, for example, or meningitis. Meningitis may occur generalized way, or even encephalitis. In those conditions, vasogenic edema can occur very commonly. Now, what about cytotoxic edema now? The cytotoxic edema is an increase in intracellular fluid secondary to neuronal and glial cell membrane injury. Okay, so there is a collection of excessive fluid. Okay, there is a collection of excessive fluid inside the cell. One is leakage of fluid from the blood vessel outside the cell into the extracellular space, and cytotoxic edema is excessive collection of fluid inside the cell itself. So the common causes are hypoxic ischemic injury or insult to the brain, and after some of the toxin exposure. So it mainly, affect in a generalized way. Now look at this picture here. This picture gives you a lot of information. See here, our brain has a typical appearance, which is called morphology of the brain. There are elevated areas on the surface of the brain, and there are depressed areas on the surface of the brain. The elevated areas are called gyri, and the depressed areas are called sulci. Gyri, okay, gyrus is the is a single one, a singular one. Gyri is the plural one. Sulcus is the singular, and sulci, okay, are the plural. Now see here, when there is a cerebral edema formation, those gyri, okay, they get flattened. Why they get flattened? You need to understand this. As a result of excessive collection of fluid, okay, the brain get expanded, and it will get compressed by the overlying skull bone. That is why the gyri will get flattened, and sulci get narrowed because they also swell up. Okay, so we cannot see those typical, okay, structure of the brain. The gyri are flattened and sulci are narrowed in case of cerebral edema. What will happen to the ventricles? The ventricles are the cavities of the brain, isn't it? Those ventricles are, of course, compressed because of excessive fluid collection. Now, what is hydrocephalus? Okay, before you go in the discussion of hydrocephalus, you should know how CSF is produced and what is the pathway of CSF. Okay, I've already explained this many times. Now see here, CSF is produced by the choroid plexus, mainly from the lateral ventricle, also contributed in third and fourth. Then that CSF will circulate and ultimately come out through the foramina of Lusca and Magendie into the subarachnoid space. Now from subarachnoid space, it is absorbed by arachnoid villi and granulations into the superior sagittal sinus. And this whole mechanism is well balanced. And how it is well balanced? Okay, remember the rate of generation, or rate of production of CSF, and the rate of absorption. It is regulating the CSF volume there. Okay, so in a normal people, okay, it remains balanced. If there is any disturbance in the balance, either in the production or in the absorption of CSF, then there is excessive accumulation of CSF inside the ventricular system of the brain, and this is called hydrocephalus. So what is hydrocephalus once again? It refers to the accumulation of excessive cerebrospinal fluid within the ventricular system of the brain. And you already know the cause now. There are two important possibilities here. One, overproduction of CSF, which is a bit rare type of mechanism, and another one, decreased absorption of the CSF, or if there is any obstruction of the CSF on its pathway. These are the important mechanism which gives rise to hydrocephalus. There are two types of hydrocephalus, non-communicating and communicating hydrocephalus. Now, many students confuse in this different term. Now, let me make this very clear right now. There are two areas which you should focus here. One area is ventricles of the brain. Ventricles are the cavity. Another area is subarachnoid space. Okay. If there is no obstruction in between those areas, if CSF is nicely flowing in between those areas, this is communicating type of hydrocephalus. Now, think again. If there is no obstruction between subarachnoid space and ventricular system of the brain, then how hydrocephalus occur? The most important reason here is the blockage of absorption site. And that blockage of the absorption site is the most common cause of hydrocephalus. Meningitis can cause hydrocephalus in this way. Okay, both pyogenic meningitis as well as tuberculous meningitis. Even subarachnoid hemorrhage can lead to hydrocephalus in this way. This is quite common. Now, on the other hand, what is non-communicating hydrocephalus? There is an obstacle or obstruction to CSF flow within the ventricular system or in the subarachnoid space. So this is also known as obstructive hydrocephalus. Okay, so the common causes has to be some masses which will compress that area, okay, and or some blood clot which will block the very small duct which is called cerebral aqueduct of Cilius. Now look at this. Look at this. CT scan here. This is communicating hydrocephalus. Okay, communicating hydrocephalus. Why it is a communicating hydrocephalus? Look at all the ventricles of the brain are dilated. Lateral ventricles, okay, these are also lateral ventricles, part of lateral ventricles. They have different horns. This is third ventricle, and this is the fourth one. So all are dilated. Okay, this picture is describing the same thing. See there, frontal horns, okay, third ventricle, fourth ventricle, and the temporal horns of the lateral ventricle. All are dilated. Now, where is the problem here in communicating hydrocephalus? I just described to you. The problem lies in the absorption site of CSF. Okay, and where is that absorption site? Okay, anyone can tell me? Excellent. That absorption site is arachnoid villi and granulations, which takes the CSF into the superior sagittal sinus. Now, look at this baby here. Okay, this has to be the congenital hydrocephalus because it may be presented from the time of birth. And looking at the age of the baby, this is congenital hydrocephalus. Look how shiny is the skull and how big is the skull. I can see a dilated vein on the surface of the skull. Okay, the skin is very stretched. Okay, the overall skull becomes huge, and the eyeball are compressed downward. So this is a typical appearance of hydrocephalus. Now this is the CT scan. Okay, and this CT scan is showing there is a colloid cyst here. Okay, this colloid cyst is blocking the flow of CSF, leading to dilation of lateral ventricle. Dilation of lateral ventricle. Third and fourth ventricles are not dilated here because they are not affected. They would not be affected by this obstruction. Only the lateral ventricles are affected. So this is a perfect example or picture of non-communicating or obstructive hydrocephalus. Now this is a true pathological specimen, and this pathological specimen is showing us, okay, see here how wide and dilated these ventricles are, okay, and when they are wide and dilated, the overlying cerebral cortex will be thinner. So this is hydrocephalus. Now what this hydrocephalus is doing to that affected portion, and what are the associated pathology there? Let's talk about it. If hydrocephalus develops in infancy before the closure of the cranial suture, there is enlargement of the head, because that head can get really enlarged because the sutures are not fused with each other. So there is expansion of the cranial cavity. But once the suture fuse, okay, even if there is hydrocephalus, there is no expansion of the cranial cavity, which exactly occurs in adult. In adult, even with hydrocephalus, there is no enlargement of the head. Okay, there is only increase in intracranial pressure, but no enlargement of the head. But in baby, before the fusion of the suture, both things can occur, especially enlargement of the head. This is called macrocephaly. Macrocephaly. Now there is one term which is called hydrocephalus ex vacuo. Hydrocephalus ex vacuo. What do you mean by that? Okay, it occurs because of the degeneration of the brain, because of the atrophy of the brain, like in cerebral infarction and some degenerative disorders of the brain, like Alzheimer's disease, for example. The overall brain shrinks so that the ventricular cavity will become bigger in size. So this is a relative thing. This is called hydrocephalus ex vacuo. Okay. After talking about these hydrocephalus, let's enter into another important aspect, which is called cerebral herniation. Important concept for you, but don't worry, we'll repeat this concept once you reach the internal medicine, okay, in the coming semester. Now herniation occurs when a part of the brain is squeezed across the structure within the skull. Now we all know the meaning of herniation. Herniation means protrusion, okay, of a viscous from the natural opening, okay, or any abnormal opening. Also, we can include that in herniation, and this is always related to the excessive pressure. So inside the cranial cavity, if a part of the brain is squeezed from some normal opening or natural opening, then this is called herniation. And what is the cause of herniation? I just told you, it is excessive pressure, okay, and that pressure is called raised intracranial pressure. And remember, there are so many causes of raised intracranial pressure because there is no excessive extra space inside our cranial cavity. So any cerebral edema, any hemorrhage inside the brain, any tumor inside the cranial cavity or brain, okay, any other pathology like neurocysticercosis, anything can lead to raised intracranial pressure, and that is the risk factor for cerebral herniation. Now, our cranial vault is subdivided by rigid dural fold, which are called falx cerebri and tentorium cerebelli, which we already discussed. Okay. So, if there is a focal expansion of the brain in some area, it will push the brain downwards through this rigid dural fold, which results in herniation. Okay. Now, what happens if herniation occurs? Remember, there are so many vital structures in our brain. There are so many important blood vessels in the brain. There are so many nerves which comes out of the brain. Those structures may get compressed by this pathology, and because of this single point, a lot of important clinical feature will be there, which is very nicely explained by this picture here. Okay, see here, there is a big blood clot which is called subdural hematoma here. Because of this subdural hematoma, the whole brain would be pushed to the opposite side. these arrows will show the same thing. It has been pushed to the opposite side. Okay, so it will lead to raised intracranial pressure. Now, because of this excessive pressure build-up, okay, the brain will be herniated downward. So there is a transtentorial herniation which has already occurred. Look at transtentorial herniation of medial temporal lobe. Okay, this is displacement and distortion of the brain stem itself. This is called central herniation. Central herniation, and this is the cerebellum. This is called tonsil of the cerebellum. It can also herniate downward. This is called tonsillar herniation. Tonsillar herniation, also known as transforaminal herniation, because this is foramen magnum. Foramen magnum. So tonsillar herniation or transforaminal herniation. Okay, and one more is right here. Okay, okay, this one. This is cingulate gyrus. The cingulate gyrus has been herniated. Okay, this is falx cerebri. So we call it subfalcine herniation because it is right underneath the falx cerebri. So subfalcine herniation of cingulate gyrus. So let me take those four names again. Okay, tonsillar herniation right here through the foramen magnum. Another very important one, transtentorial herniation of the medial temporal lobe, also known as uncal herniation. Okay, this is occurring through the, see here, this is called tentorial hiatus. Okay, look this area. This is tentorium cerebelli. Okay, there is a opening in the middle of the tentorium cerebelli. Through that opening, the brain stem is going downward. So through this gap, okay, if herniation occur, we call it transtentorial or uncal herniation. Central herniation, the whole brain stem is herniated downward, and subfalcine herniation is right here. Now, okay, so these are the different types of herniation I talked about. So you can look at the name here. The central herniation is not very commonly mentioned in different textbook, so you can skip there this here. So only three other remaining types are highlighted, that is subfalcine or cingulate herniation, okay, transtentorial herniation, and the tonsillar herniation. Now, subfalcine herniation occurs when unilateral or asymmetric expansion of a cerebral hemisphere displaces the cingulate gyrus under the edge of the falx cerebri. We already understood the mechanism. And there is anterior cerebral artery very nearby, so that anterior cerebral artery may be compressed by cingulate herniation. Now what happens if anterior cerebral artery is compressed? Remember, which areas of our brain is supplied by anterior cerebral artery? That question is so important. The medial aspect of the cerebral hemisphere is supplied by that. So that area would be ischemic. The second type of cerebral herniation is a transtentorial or uncal herniation or uncinate herniation. This is the term we use for medial temporal lobe of the brain. And it occurs when the medial aspect of the temporal lobe is compressed against the free margin of the tentorium cerebelli. Please don't forget your anatomy. Okay, there is a tentorium cerebelli which is situated right in between the supratentorial compartment and infratentorial compartment, and there is an opening there. Okay, through that opening, brain stem is going downwards. Now, if there is high rise in intracranial pressure, that pressure will push the temporal lobe against the free margin of the tentorium cerebelli, and this is called transtentorial herniation. Now what will happen? The structures which are present there will be compressed. One of the important structure is third cranial nerve. What is the name of third cranial nerve? Yes, you're right. This is oculomotor nerve. What is the function of oculomotor nerve regarding the pupillary size? I'm sure many students know this. Third cranial nerve is a parasympathetic nerve. So what is the parasympathetic function for the pupil? Constriction. But this nerve is damaged here, right? So what will happen? the pupil will be dilated. This is called blown pupil. Pupil is dilated and fixed. This is a very important clinical feature. At the same time, posterior cerebral artery may also be compressed, resulting in ischemic injury to the area which is supplied by that artery, especially the occipital cortex. And our visual cortex is present in the occipital lobe. So the person will become blind. Now once again, the same types of herniation are shown here: subfalcine herniation, transtentorial herniation, and tonsillar herniation. Now we are talking about transtentorial herniation for the time being, so let's continue. If the amount of displacement of the temporal lobe is large enough, the pressure on the midbrain can compress the contralateral cerebral peduncle against the tentorium, which results in hemiparesis ipsilateral to the side of the herniation. It is called as false localizing sign. So let me explain this in a very easy way for you. Now see here, what is happening? Let's talk about one side here. Okay, let's talk about the right side. Say the right uncus or uncinate process of the temporal lobe is herniated, okay, from that area. So in the beginning, what will happen? In the beginning, okay, the same area would be compressed. But if the compressment or the pressure is way high, then it will push the whole side, okay, to the opposite one, opposite end or opposite side. Okay, so the cerebral peduncle, which is coming downwards, okay, from the left side, will also be compressed against the edge of the tentorium cerebelli, and this results in hemiparesis. Okay, hemiparesis, which occurs on the ipsilateral side of the herniation, because this cerebral peduncle will go downwards, and when they reach the medulla oblongata, remember which type of fibers are they carrying? They are carrying corticospinal fiber. So they will crush at the medulla oblongata, okay, that is called pyramid area or pyramidal area, so that they will again come towards the same side. That's why when opposite cerebral peduncle or contralateral cerebral peduncle is compressed against the edge of the tentorium, the hemiparesis, means paralysis of half of the body, occurs on the same side of the pathology or herniation, and this is called false localizing sign. Now there is a term which is called Cornohan's notch. This Cornohan's notch is a compression of the peduncle, that is cerebral peduncle, and this creates one deformation which is called Cornohan's notch. Important MCQ question for you. And because of this consistent pathological process, some flame-shaped or linear hemorrhage occur in the midbrain and pons, which are known as Durate hemorrhage. Okay, Durate hemorrhage, and this Durate hemorrhage occur because of the tearing of the veins and the arteries which supply that area. So blown pupil, okay, hemiparesis ipsilateral to the side of the herniation, which is called false localizing sign, Cornohan's notch, and Durate hemorrhage. All of these are very important points in transtentorial herniation. Now the third one, tonsillar herniation. This refers to the displacement of the cerebellar tonsil through the foramen magnum. Okay, so the name itself suggests, very easy to understand. These tonsils are the part of cerebellum. When the pressure is excessively high inside the cranial cavity, those tonsils may be herniated through the foramen magnum. This is the most, pathological or life-threatening among all of the herniation, because it will directly give compression to the medulla oblongata, and there are vital centers there, so the patient can die instantly. Now this slide is compiling all the important points which I have just discussed here. Okay, so let me quickly revise this. There is the site of herniation. Importantly, two important herniation are highlighted here: transtentorial and tonsillar herniation through the foramen magnum. So these are the effects. ipsilateral third cranial nerve compression, of course. Ipsilateral sixth cranial nerve compression. This is also known as false localizing sign. Posterior cerebral artery compression, which we already talked about. Cerebral peduncle compression, okay, which may occur on the contralateral side, and brainstem compression and hemorrhage. These are called Durate hemorrhage. Okay. Now, what happens clinically? If third cranial nerve is affected on the ipsilateral means same side. There is fixed and dilated pupil on the same side. Okay. If ipsilateral or same side, sixth cranial nerve is compressed. Now, the function, what is the function of sixth cranial nerve? Which muscle is supplied by sixth cranial nerve or abducens nerve? Lateral rectus muscle. So there will be convergent squint because medial rectus is still normal. So there will be convergent squint in the patient, and the patient will complain of double vision. This is called horizontal diplopia. If cerebral artery or the posterior cerebral artery is compressed, there will be occipital infarction and cortical blindness. Very easy to understand. If cerebral peduncle is compressed, remember which fibers are present in the cerebral peduncle? Which fibers are those? Yes, they are corticonuclear and corticospinal fiber. So we have upper motor neuron sign. And if brainstem is compressed and if there is bleeding, which are called Durate hemorrhage, the person can have decerebrate posture, as well as there may be failure of the cardiorespiratory system, and usually it may lead to death. Decerebrate and decorticate posture, these are two important terms. Decerebrate posture means all four limbs are extended and the person is in deep coma. Decorticate posture means the upper limbs, especially the elbows, wrist and fingers, are flexed and the lower limbs are extended and rotated inward. This is called decorticate posture. So only one difference: in cerebrate posture, everything is extended and rotated inward, but in decorticate posture, okay, decorticate posture, the upper limbs are flexed and lower limbs are extended. Now, if foramen magnum, okay, or we have to say tonsillar herniation here. Okay, see that this is the important effect. Brainstem compression and hemorrhage can occur, which can lead to death of the patient. And along with that, there is acute obstruction of CSF pathway, because CSF is passing from the subarachnoid space towards the subarachnoid space of spinal cord, I should say. It is going towards the spinal cord through that area, so it is acutely obstructed there, resulting in severe rise in intracranial pressure. So these are the different aspects of cerebral herniation. One very important practical knowledge I like to provide you before I close this topic. When you are doing lumbar puncture without checking whether there is increased ICP or not, there will be a fatal effect of that. Now, how that happens? Okay, in case of raised ICP, what is happening to the brain? The brain is trying to go downwards. So if you are doing lumbar puncture, you are helping that process by releasing the pressure. If you have not done some examination before, if you don't know how much increase in intracranial pressure is there, you can induce this effect in the patient, which can result in tonsillar herniation and result in death of the patient. You are doing a lumbar puncture, but you may not realize the patient is already dead. So please remember, before doing lumbar puncture, you should always check whether there is raised ICP or not. And how we do that? That is done by fundoscopic examination. Look for the papilledema. If papilledema is present, don't go for lumbar puncture. And another one is do CT scan before doing all these things. At the end, I have compiled some questions from this topic. Please go through them and answer these questions. Hello everyone, good evening. So today I'm going to talk about one of the very important concept, or I should say topic, in neurology.
Right now, actually, this topic I'm going to teach to the pathology student in central nervous system pathology. But nevertheless, after this semester, you are going in clinical phase. So before you go there, you should know very well about what is upper motor neuron, what is lower motor neuron, what is the pathway of corticospinal tract, what happens when these corticospinal tracts are damaged, and things like that. Okay, so let's talk about this. Let's utilize this precious time. Fine. Now, what do you mean by upper motor neuron and lower motor neuron? Now, look at this picture very carefully. This is the brain. Okay, this is our brain, and here is the spinal cord. This is the cross section of spinal cord. From the brain, one neuron is coming. Okay, one neuron is coming, right? And then that neuron is synapsing to the motor neuron or anterior horn shell neuron. Okay, and one important point which is not properly shown in this picture, this neuron will also synapse in this area. Okay, in this area, especially in the brainstem, from where the cranial nerves are coming, or in other words, in the cranial nerve nuclei, this particular neuron is also synapsing. So there are two areas where this neuron will synapse. One in the brainstem, where the cranial nerve nuclei are located, and another in the anterior horn cells of the spinal cord. So this neuron is called upper motor neuron, and from anterior horn cells to downwards, or from the cranial nerve nuclei downward, this is called lower motor neuron. Now you already know the concept. So two motor neurons, an upper and lower motor neuron, together form the basic neural circuit involved in the voluntary contraction of skeletal muscle everywhere in the body. So whenever you study about neurology, these two terms will keep on coming to you, and you must know the difference. Now, once again, okay, a little bit of elaboration. The LMN or lower motor neurons are found in the ventral horn of the spinal cord and in cranial nerve nuclei in the brainstem. So these are two types of lower motor neuron. Let's take one example. Median nerve, radial nerve, ulnar nerve, sciatic nerve, all of these are lower motor neuron. Whereas cranial nerve, take all the names of those cranial nerve like facial nerve, okay, glossopharyngeal nerve, vagus nerve, these are also lower motor neuron. Now, the axons of lower motor neuron of spinal nerve, they exit in a ventral root, then join the spinal nerve to course in one of its branches to reach and synapse directly at a neuromuscular junction in the skeletal muscle. This is how the lower motor neuron from the spinal cord goes to the muscle. So we all know from the ventral horn, okay, the motor neuron arises. So it goes outside from the ventral root, then it fuses with the dorsal root, form spinal nerve, isn't it? Then spinal nerve again divided into two branches, dorsal ramus and ventral ramus, okay. Then through its branches, it will go to the skeletal muscle. Axons of lower motor neuron in the brain stem exit in a cranial nerve out of those 12 cranial nerve. Now, this picture is telling us the same thing. This is a cross section of the spinal cord. Here is the ventral root. This is the dorsal side. Here is the ventral side. So this is the ventral root. So from there, the motor nerve is coming. This is a lower motor neuron. It goes outside through the ventral root. See there, ventral root. Dorsal root is here. There is a dorsal root ganglion always towards the dorsal root side, and these two combine together to form a spinal nerve. Now again, it will divide into dorsal ramus and ventral ramus, and it goes to the muscle and synapse there. So this whole nerve, this whole nerve is a lower motor neuron. Now, what about upper motor neuron then? Now, upper motor neuron starts from the brain. Okay, there's no doubt about it. And there are two ends of upper motor neuron. One at the brainstem, and second in the spinal cord. So, to initiate a voluntary contraction of skeletal muscle, a lower motor neuron must be innervated by an upper motor neuron. That means the upper motor neuron is giving command to the lower motor neuron to do its action. The cell bodies of upper motor neurons are found in the higher center. Okay, the most important location is cerebral cortex, but they are also found in red nucleus, reticular formation, and vestibular nuclei of the brainstem. Okay, so we have got two sources. To be very precise, we have got two sources. One pyramidal tract, another is extrapyramidal tract. Pyramidal tract originates from the cerebral cortex, and extrapyramidal tract originates from those areas which we have just listed. Now this picture will tell us everything. This is the brain. Okay, this is the source of the upper motor neuron. It reaches to the spinal cord where it synapses, and from there the lower motor neuron originates. Another type of lower motor neuron, which is not shown here in the picture, lies in the brainstem. Now, after getting this concept, let's talk quickly about what are the descending tract present in the spinal cord. Now, there are different types of descending tract present in the spinal cord. They are roughly divided into pyramidal tract and extrapyramidal tract. So they are either originating from the cerebral cortex or brainstem. So pyramidal tract is also known as corticospinal tract, whereas extrapyramidal tracts consist of so many different names, like rubrospinal tract, which originates from the red nucleus. Vestibulospinal tract arises from the vestibular nucleus. Tecto arises from the tectum. So tectospinal tract we say. Tectum is an area of midbrain. Reticulospinal tract arises from the reticular formation, and corticobulbar tract. Okay, cortico means cerebral cortex, bulbar means brainstem. So these are also known as corticonuclear tract. Now look at this picture here. This is the cerebral cortex. Okay, so this is, okay, just trace this line. See here, corticospinal tract, and where it is ending, the spinal cord. So other upper motor neurons are also there. Okay, or descending tracts are also there, like tectospinal tract, reticulospinal tract, vestibulospinal, and lateral corticospinal. Actually, corticospinal is divided into anterior and lateral tract. We'll talk about that later. Now, this is a cross section of the spinal cord which is showing these tracts. See here, lateral corticospinal tract and anterior corticospinal tract, shown in the this color. Okay, red rubrospinal tract, which comes from the red nucleus. Vestibulospinal tract comes from the vestibular nucleus. Reticulospinal tract from the reticular formation. Okay, and tectospinal tract from the tectum of the midbrain. Now, today we are mainly focusing on the corticospinal tract, which is absolutely necessary for every student to know about it in detail. So from where it originates, okay, how it goes downwards, and what are the functions. So let's talk about its origin first. It originates from cerebral cortex and terminates into the spinal cord. That's why the name corticospinal tract. And it has two important types, lateral and anterior. The lateral corticospinal tract is made up of corticospinal fiber that have crossed in medulla oblongata, especially in the pyramidal area. After it decussate or cross over in the pyramid, then it forms the lateral corticospinal tract. It supplies all levels of spinal cord, right from the cervical to the lumbosacral area. Now, anterior corticospinal tract is made up of uncrossed corticospinal fiber that cross near the level of synapse with lower motor neuron. So what do you mean by that? Okay, remember in pyramid, okay, almost 90% of the fiber cross and goes to the opposite side. They form lateral corticospinal tract. But about 10% of the fiber, they don't cross. They just descend downwards like that. This is anterior corticospinal fibers. But they also cross and goes to the opposite side. But where? That is the question. Where? It is near to the level of lower motor neuron in the anterior horn cell. And it supply neck and upper limbs area only. Now, what are the layers of cerebral cortex from where those corticospinal fibers are originated? So when you go through these layers, you know your answer. Cerebral cortex have 6 layers. Okay, layer 1 to layer 6. Layer 1 is called the molecular layer. Just knowing the name is enough here. Layer 2, the external granular layer. If you want to know in detail, please go through the histology textbook and know in detail. Layer 3, the external pyramidal layer. Layer 4, the internal granular layer. And layer 5, the most important one, is internal pyramidal layer, which has a large cells known as bed cells. Okay, these bed cells are one of the major contributor of corticospinal fibers. And layer 6, the polymorphic or multiform layer. Now, what are the functions of this corticospinal tract? Now, remember, before going into the detail here, okay, let me revise one sentence quickly. Lower motor neuron, whether they are present in the brainstem or spinal cord, they are controlled or supplied by upper motor neuron. That means corticospinal tract. So it causes rapid and skilled voluntary movement, especially distal end of a limb. So these rapid and skilled voluntary movements are controlled by corticospinal tract. And the superficial reflex are also controlled by corticospinal tract. That means in case of upper motor neuron lesion or in case of corticospinal tract damage, all the superficial reflex are gone, like abdominal reflex, okay, a cremasteric reflex and plantar reflex. They become lost or abnormal. Now let's talk in detail about pathway of corticospinal tract. Okay, so you should focus in this part very nicely. Now what is the origin? See here, these fibers, they arise as the axons of pyramidal cells from the 5th layer of cerebral cortex, from the 5th layer. And in case of a primary motor cortex, these cells are known as bed cells. But 30% of the fiber from primary motor cortex, 30% from premotor and supplementary motor cortex, and 40% from somatic sensory area, which is posterior to the central sulcus, and they are also contributed by parietal lobe of the brain. Okay, so different type of sources are there. After the origin, these fibers converge at corona radiata. Then they travel on the posterior limb of internal capsule. This is very important anatomy. Internal capsule carries all these pyramidal fibers. Okay, in which part of the internal capsule? Posterior limb. From internal capsule, they descend through the length of the brain stem in the ventral portion of the midbrain, pons, and medulla. Okay, so they travel the most of the length of brain stem. The brain stem means midbrain, pons, and medulla. So where in midbrain these fibers they travel? Just think about it. Where in the midbrain? In cerebral peduncle. one part of the cerebral peduncle is called cross cerebri. So this cross cerebri contains the fibers. Where? In pons. Okay, the anterior most part of the pons. And where in medulla? Okay, the anterior most part. And in the pyramid, these fibers will decussate. In the lower medulla or at the area of pyramid, 80 to 90% of the corticospinal fiber cross and continue in the contralateral spinal cord. Contralateral means opposite side as the lateral corticospinal tract. They descends the full length of the cord in the lateral part of the white matter, also known as lateral funiculus. And how far they go? Okay, they synapse at the ventral horn cells from where the lower motor neuron arises. Now, what happens to the remaining 10% of the fiber? They don't cross at the decussation of pyramid. They descend in anterior column as anterior corticospinal tract as such. Remember, they don't cross at this stage. But they eventually crosses to the opposite side very near to the anterior horn cells. Okay, they only supply cervical and upper thoracic area. Now let's talk about this pathway with the help of a diagram. See here, this is the cerebral cortex. Okay, this is the origin of the corticospinal fibers. This is called corona radiata. Corona radiata. This area is internal capsule. Okay, internal capsule, and these are the brainstem area. So cerebral peduncle. Cerebral peduncle means this is midbrain. Okay, then pons. Okay, the innermost area, and in the pyramid of medulla oblongata. See here. So motor nuclei of cranial nerve. These cranial nerves are also supplied by corticospinal tract. We call that corticonuclear tract to be very precise. And this is anterior corticospinal tract, and this is the lateral corticospinal tract, and ultimately it has ended on the spinal cord, and from there the lower motor neuron arises, which ends in the skeletal muscle. Now let's talk about what happens when these corticospinal tract are damaged. What will happen to the person? One very important point you need to remember here is where is the decussation point or crossing over of this corticospinal fiber. That is at the medulla. 90% of the fiber they cross at the medulla. Okay, so this is a very significant point if you want to know what happened to the person. If the lesion of corticospinal tract occur above the decussation or above the crossing over area, then the effect is seen at the contralateral side of the body. Contralateral means opposite side of the body. For example, if the corticospinal tract above the decussation is damaged at the right side, okay, then the body will be paralyzed on the left side. This means contralateral side. If the lesion of corticospinal tract occurs below the decussation, then the effect is seen at the ipsilateral side of the body, because the crossing over has already happened. Okay, after that there is no more crossing over. That's why wherever the lesion occurs, the same side paralysis will also occur. So what happens to the person overall? What are the other effects? There is loss of performance of the fine skilled voluntary movement. That is a function of the corticospinal fiber. So there is loss of fine motor performance. When we examine the plantar reflex, okay, when we examine or elicit plantar reflex will be abnormal. It will be extensor plantar reflex, and this is known as Babinski sign. So what do we mean by extensor plantar reflex or Babinski sign? In this condition, great toe become dorsally flexed, means it goes up, it goes towards the sky, and the other toe they fan outward in the response to scratching the skin along the lateral aspect of the sole of the foot. This is how we elicit plantar reflex. It is better elicited than describing here. It's very easy actually. Just know what happens in Babinski sign. In normal person, if we scratch the lateral aspect of the sole of the foot, the great toe will flex towards the ground. But in Babinski sign, it will go upward, and the remaining toe they fan outside or outwards. Now, superficial reflexes are lost in pyramidal tract lesion like abdominal reflex, cremasteric reflex, etc. They are lost. They are not present. So see here, this is Babinski negative, which is present in the normal person, and Babinski positive is present in pyramidal tract lesion or corticospinal tract lesion or upper motor neuron lesion. Look what is happening to the great toe, going upward, and all the other toes are fanning outwards. Now we have come towards the end. What are the differences between upper motor neuron lesion and lower motor neuron lesion? Now, first of all, what do you mean by this upper motor neuron lesion? Lesion means disease or damage. So you already know the definition of upper motor neuron, right? So any lesion or damage or disease of those upper motor neuron are called upper motor neuron lesion, and similarly lower motor neuron lesion. Now look at this table. In upper motor neuron lesion, these are the clinical features. In lower motor neuron lesion, these are the clinical features. Spastic paralysis versus flaccid paralysis. Spastic means spasm. Spasm means contraction of the muscle. That means the tone is excessive. So excessive tone with paralysis is a feature of upper motor neuron lesion, and loss of tone, which is called flaccidity, and paralysis is the feature of lower motor neuron lesion. If we elicit reflex of the deep tendon reflexes of the upper limb as well as the lower limb, there will be hyperreflexia in UMN lesion, whereas in LMN lesion there will be absent of the reflex. This is called areflexia. Hyperreflexia or exaggerated reflexes versus areflexia. In upper motor neuron lesion, Babinski sign is present. In lower motor neuron lesion, there is no Babinski sign. Okay, increased muscle tone versus decreased muscle tone. In LMN, okay, very decreased, reduced muscle tone or flaccidity. In upper motor neuron lesion, increased muscle tone. There is one important point here. In lower motor neuron, which is called fasciculation, that means the twitching of individual muscle fiber are a very prominent feature in LMN lesion. Muscle weakness is seen, okay, in both conditions. Diffuse atrophy of the muscle is seen in upper motor neuron, whereas marked atrophy of the muscle is a hallmark of lower motor neuron lesion. There is decreased speed of the voluntary movement in UMN because that is a function of corticospinal tract, whereas in LMN there is no movement at all. And in UMN, large area of the body is involved, whereas in LMN, small area of the body is affected because probably one or two lower motor neurons may be affected. Now, at the end, what are the types of paralysis in case of these neuronal involvement? Look at the terms here: hemiplegia, monoplegia, paraplegia, and quadriplegia. Now, before I go into the individual discussion, there is a small point I like to highlight. There is a difference between plegia and paresis. Plegia means dense type of paralysis or severe type of paralysis. Paresis means minor form of paralysis. Please remember that. Now, hemiplegia is paralysis of one side of the body, which include upper limb, one half of the trunk, and the lower limb. Monoplegia, paralysis of only one limb. Mono means only one limb. Paraplegia, very important term, when spinal cord is damaged. Usually paraplegia or paraparesis occur. That means paralysis of two lower limbs or both lower limbs. And quadriplegia, quadri means four. So paralysis of all four limbs, known as quadriplegia, also known as tetraplegia in some of the textbook. Okay. So at the end, I've compiled some of the questions. Please go through them and solve. Good evening, everyone. So today I'm going to talk about central nervous system infections under CNS pathology. This is a very important topic because very soon you are moving onto the clinical phase, and when you move onto the clinical phase, while going to the hospital or when you start working in the hospital, you will see many CNS infection cases. So it will give you a very, very good overview of the central nervous system infections. Now, this CNS infection means it comprises of meningitis, okay, encephalitis, brain abscess, and cerebral malaria. These are the common central nervous system infections. But right now, inside this topic, I'm going to talk about meningitis, the different forms of meningitis like pyogenic meningitis, okay, then viral or aseptic meningitis, followed by tubercular meningitis, and then something about viral encephalitis. Finally, it will be followed by brain abscess. Now, the first thing is how microorganisms reaches the brain or how they reaches central nervous system. There are four common routes by which the infectious microbe enter the nervous system. Okay. The most common one is the hematogenous spread or through the blood. Now, a common question which will arise in the student's mind is how organism reaches the blood first, isn't it? Now, there are different ways by which it reaches the blood. Now, think about it. It may occur because of trauma. It may occur because of surgery. It may occur because of IV infusion. It may occur because of sharing of the needle. It may occur because of some dental procedure. Okay, when you go to the dentist and if the dentist do something in the teeth, that is one of the very common way of bacteremia. So these are some of the common way. And let's not forget, it may reach the blood from other organ. For example, first those organs are infected, then that may be the source for bacteremia and septicemia. You can take a lot of example under this heading, like pneumonia, pyelonephritis, okay, osteomyelitis, septic arthritis, skin abscess, so many things. The second route is a direct implantation of microorganism that may be by trauma or by iatrogenic. Iatrogenic means doctor induced, okay, and that is mainly by surgery. Third one is a local extension from sinus, mastoid cavity of the ear, and infected tooth, which are very nearby structures. The sinuses means paranasal sinuses. They may be frontal sinus, they may be maxillary sinus, they may be ethmoidal sinus or sphenoid sinus. But the common one are frontal and maxillary. Mastoid cavity infection is very common in children. This is called otitis media, one of the commonest infection in children, and that may be the source of infection which may cause central nervous system infection. Infected tooth can be some other cause of central nervous system infection because it is very nearby. From the peripheral nervous system, rabies and herpes zoster may enter the central nervous system through the nerve, through the ascending route, isn't it? So this is another way. Now, What is meningitis? Okay, what are the types and what are the clinical feature and what are the causative agents? Let's talk about it. Meningitis is defined as inflammation of leptomeninges. Now, every student know what is leptomeninges, isn't it? Meninges has three layers. Outermost layer is called dura mater. The middle one is arachnoid matter, and the innermost is called pia mater. Now, leptomeninges is the term which only includes arachnoid and pia mater. Dura mater is not included in leptomeninges. That means dura mater is not inflamed in case of meningitis. It may be inflamed, but we don't need that in our definition. Along with leptomeninges, subarachnoid space is also involved. That means CSF is present inside the subarachnoid space. So CSF has got a very important finding in case of meningitis. That's why when we do lumbar puncture and take the CSF out and send to the lab, it will give us the diagnosis. Now, meningitis is mainly caused by infection, and there are different types of meningitis like acute pyogenic, also known as acute bacterial meningitis, usually caused by pyogenic organism or bacteria. Aseptic meningitis, this is usually acute viral meningitis. Aseptic means no pus formation. Remember the term. Aseptic means no pus formation. Chronic meningitis, mainly tubercular. It may be spirochetal, like syphilis, or it may be fungal. Can you name one of the common fungi which can lead to chronic meningitis? Very good. This is Cryptococcus neoformans. That is the fungus. Now, there is a term known as meningoencephalitis. That means inflammation of both meninges as well as brain parenchyma. This is called meningoencephalitis. There are different viruses which can lead to meningoencephalitis, or even some of the bacteria can lead that. Now, what are the causative agents of acute pyogenic meningitis? The name itself suggests there is pus formation inside the brain, especially in the leptomeninges. Okay, and the common causative agents are in neonatal age group. Group B streptococci, E. coli, and Listeria monocytogenes are the common one. Okay, Group B streptococci, E. coli, and Listeria monocytogenes. They are the very common organism which cause infection in neonatal group. And mostly these organisms are derived from the or obtained from the maternal genital tract. In infants and children, now many students may not know the meaning of neonate and infant. So neonate means first 28 days after birth. Okay, and infant is up to 1 year, up to 12 months. So in infants and young children, Haemophilus influenza is very common agent to cause the infection or meningitis. In adolescent and young adult, Neisseria meningitidis and Streptococcus pneumoniae are quite common to cause the infection. And in elderly population, again Streptococcus pneumoniae and Listeria monocytogenes. These Listeria monocytogenes mainly cause infection in the immunocompromised setting. Now, what is the morphology in case of acute pyogenic meningitis? What happens to the brain? If we examine the brain grossly or even microscopically, what we see? There is neutrophilic infiltration of the leptomeninges because we are talking about acute pyogenic meningitis, which extend variably to the cerebral cortex as well. The leptomeninges will become opaque because of the pus deposition there, and there is diffuse cerebral edema because of severe inflammation. And this cerebral edema will lead to increase or raise intracranial pressure. And this intracranial pressure may lead to fatal complications like cerebral herniation, especially if the physician or the doctor perform lumbar puncture without checking how much intracranial pressure rises there. Okay, or if they fail to diagnose raise ICP, then there is a fatal chance of cerebral herniation. What are the clinical features of acute pyogenic meningitis? How we diagnose it? The patient will have severe headache, high grade fever. Okay, this fever is high grade. At the same time, many people complain of vomiting, and this vomiting is projectile type of vomiting. There is rigidity of the neck. Some people may complain it from their side, and some other we have to find out during examination, which is called stiffness of the neck or rigidity of the neck. Another one is cloudy sensorium. The person may be drowsy, okay, in the beginning, and later on the person may be comatose. And ultimately, if the treatment is not provided in time, it may lead to death. Okay, so these are some of the very important points. Now, if the meningitis is caused by meningococci or Neisseria meningitidis, and also sometimes by pneumococcal meningitis, there is hemorrhagic infarction of bilateral adrenal gland, and this condition is known as Waterhouse-Friderichsen syndrome. Remember, Waterhouse-Friderichsen syndrome is mainly connected with meningococcal septicemia. Now, what is the function of adrenal gland? Okay. These are very important endocrine organ for us, and they are considered one of the vital organs in our body. Okay, they secrete different hormones. The most important are glucocorticoids and mineralocorticoids, and without them, life is impossible. So, in Waterhouse-Friderichsen syndrome, there is severe shock in the patient. We need to identify this in time and going for the treatment. Otherwise, patient may die. Now, apart from those, there are many other clinical features in acute pyogenic meningitis, like Cornick sign and Brudzinski sign. Cornick sign and Brudzinski sign, along with neck rigidity, are also known as sign of meningeal irritation. Okay, signs of meningeal irritation, because these signs are there because of irritation or inflammation of leptomeninges. If meningitis is not treated in time, or even if we treat meningitis effectively, there will be some sequelae formation. Sequelae means some outcome will be persisting there. And this is mainly because of organization of purulent exudate and fibrosis. And the common sequelae or complication, we should say, are hydrocephalus and cranial nerve impairment, and sometimes even hemiplegia, okay, of one half of the body may occur. Among cranial nerve impairment, deafness is very common in case of meningitis. The person cannot hear as a neurological sequelae. And what type of hydrocephalus is more common in meningitis? Remember, this topic was already discussed before. There are two types of hydrocephalus: communicating hydrocephalus and non-communicating hydrocephalus. As a result of meningitis, okay, mainly the absorption site of the CSF is affected, and because of the lesion in the absorption site of the CSF, which hydrocephalus occur? Communicating. It is called communicating hydrocephalus. Now, another type of meningitis is known as aseptic meningitis or viral meningitis, and there is a inflammation of leptomeninges because of viruses. Enterovirus are most frequent organism, like Eco, Coxsackie, and polioviruses. Okay. Now, if we analyze what is happening in the leptomeninges, there is lymphocytic infiltration because these are viral infections, and many of the time the superficial cortex is also affected. Regarding the clinical features of viral meningitis, the fever is low grade. In comparison to bacterial meningitis, the fever is low grade here, but in bacterial meningitis, it is high grade. There will be signs of meningeal irritation like neck rigidity, Cornick sign, and Brudzinski sign, as well as depressed consciousness level. In comparison to the bacterial meningitis, viral meningitis has a very low mortality, and many of the patients will recover by themselves. Just symptomatic treatment is necessary. Now, mycobacterial meningoencephalitis is the third type of meningitis we are going to talk now, and this is caused by Mycobacterium tuberculosis or atypical mycobacteria, maybe Mycobacterium avium intracellulare, but the commonest agent is Mycobacterium tuberculosis. This is a chronic type of meningitis, okay, chronic. It usually involves the basal surface of the brain, and all cranial nerve comes out from the basal surface of the brain. So without any hesitation, a student can answer there will be involvement of cranial nerve as a result of tubercular meningitis. One more important thing here, there will be presence of tuberculoma within the brain and dura mater. Now, tuberculoma is a space occupying lesion or granuloma in case of tuberculosis. In case of AIDS patient or acquired immunodeficiency syndrome patient, Mycobacterium avium intracellulare commonly cause infection, and it may be the cause of mycobacterial meningoencephalitis. Now, regarding the clinical features, there will be headache, vomiting, confusion, drowsiness, or coma. Fever may be there, and this fever is low grade fever, especially in the evening time, and there will be sweating along with fever. Patient will lose weight and loss of appetite, which is a very common feature of any type of tuberculosis. Okay, any type, not only in tubercular meningitis. In any type of tuberculosis, these clinical features will be there. Now, one important point here, how this tubercular organism reaches the brain. Okay, remember, what is the carrier of this Mycobacterium tuberculosis organism? Macrophages. They travel through the macrophages. Okay. Now, common complication of mycobacterial meningoencephalitis are hydrocephalus, similar like in acute pyogenic meningitis complication. This is also a communicating type of hydrocephalus, and it can also lead to brain infarction, okay, as a result of obliterative endarteritis. Means some of the areas of the brain would be ischemic because of the involvement of the blood vessels. Now, one of the very important point I like to highlight here now is how to diagnose meningitis. Okay. Now, any type of diagnosis, okay, any type of diagnosis, any disease, if you want to diagnose, we have a certain pattern. We always start from history taking. History taking means symptoms. What are the symptoms present in the patient? Followed by physical examination, or what are the signs present in the patient? And third one, we do investigation. Okay, we do certain investigation and send to the lab. Now, in case of CNS infection, or especially in meningitis, that investigation is CSF examination. That is the most important examination or investigation here. Of course, we do complete blood count. Okay, we always do that, and we also go for CT scan of the head or even MRI. So never forget these three important investigation in case of meningitis: CSF examination, complete blood count, along with blood culture also is done, and CT scan of the head or MRI examination. Now, what I like to highlight here is what are the CSF parameter or finding in different forms of the meningitis. Okay, look at this slide very carefully. Now see here, these are the normal values of CSF. Even in the normal people, these are present. So the number of cells present in the normal CSF are less than 5, and they are all lymphocyte. All lymphocyte. There should not be even one neutrophil present in the CSF. Now, how much glucose is present there? Okay, how much glucose? The glucose is present, we say it is 2/3 of the blood sugar. 2/3 of blood sugar. Okay, so we should always send blood sugar in the lab, and 2/3 of the blood sugar is considered the normal CSF glucose. Protein is 15 to 45 milligram per deciliter, and pressure, which is measured in millimeter of water, it is about 70 to 180 millimeter of water. These are the normal values. Now, what happens in acute pyogenic or acute bacterial meningitis? There will be high number of cells, and mostly those cells are neutrophil. Okay, high number of cells or very increased number of cells, almost all of them are neutrophils. Regarding the glucose, it is decrease. Never forget that this is a very important point. Glucose level in CSF is very decreased in case of acute pyogenic meningitis. What happens to the protein level? This is an exudative condition. There is a pus formation. So protein content is always increased in CSF. Okay, it is always increased. Regarding the pressure, it is markedly elevated. If you measure the pressure, it is very high. Now, what happens in viral meningitis? The cells are increased, okay, but not as high as bacterial meningitis, but they are high, okay, in the range of 100 to 1000, and they are mostly lymphocyte. Regarding the glucose, it is normal. Protein is increased, but not as highly as a bacterial meningitis, and pressure is slightly elevated. Regarding tubercular or fungal, both of them are chronic type of meningitis. Cells are again increased, just in the range of viral meningitis, and again they are mostly lymphocyte because this is a chronic form of meningitis. Regarding the glucose, it is decreased now. That is the big difference between viral meningitis and tubercular meningitis regarding CSF examination. Okay, glucose is normal in viral meningitis, whereas glucose is decreased in CSF in case of tubercular meningitis. What happens to the protein content or level? It is increased, more increased than the viral one, and pressure is also higher than viral meningitis. Now, I've already talked about the important differences between these different forms of the meningitis, but after you take CSF, you always send a certain test, isn't it? Many of the tests are already highlighted there. Okay, I like to repeat it again. First, you want to see what is the color of the CSF. Normally, the CSF is crystal clear, like a water in color. If it is turbid or hazy or pus-like, a color, then of course it is abnormal. Then you send it for the glucose level, the protein level, okay, RBC and WBC. We send all of these things to the lab, and another type of test we do is a gram stain, okay, AFB stain, and culture and sensitivity test. So these are a routine, investigation from CSF sample. Let's talk about viral encephalitis now. What is the difference between meningitis and encephalitis? After going through this discussion, it will be easy for you to understand. Now, encephalitis is inflammation of the brain parenchyma, and most commonly they are caused by viruses. So we usually say viral encephalitis. The common features in viral encephalitis are there is perivascular coughing. Perivascular coughing means on the edge of the blood vessel inside the brain, there will be deposition of lymphocyte, macrophages, and plasma cell. There is, formation of microglial nodules. There will be neuronal loss as well as neuronophagia by the inflammatory cells. These are also important findings in case of encephalitis. Now, regarding the clinical manifestations of encephalitis, okay, it is highly variable. Some patient may present to the hospital in a state of coma, but some other are simply in the drowsy state. Fever is usually low grade. Okay, fever is usually low grade, and the patient may also complain of severe headache because there is usually raised ICP in this type of cases. And many of the people, they already develop a lot of neurological sequelae. Now, what are the common causes of viral encephalitis? Now, see there, okay? Japanese bee encephalitis is quite common, okay, especially in the tropical countries. In the South Asian countries also, Japanese encephalitis is very common. This is arthropod-borne viral encephalitis. Mainly the Culex mosquito is responsible. Herpes simplex virus type 1 and herpes simplex virus type 2 can also cause viral encephalitis. Varicella zoster virus can also lead to viral encephalitis. Cytomegalovirus, poliovirus, rabies, and even HIV can lead to viral encephalitis. But from the exam point of view, Japanese encephalitis and herpes simplex encephalitis are more important than other. And know a bit about the rabies as well. Now, there are certain specific forms of viral encephalitis like herpes simplex type 1 and rabies. Why these are important? Because some MCQ question can be directly asked from there. Okay? In HSV encephalitis, there is hemorrhagic necrosis of temporal lobe of the brain. So when we do CT scan, we can specifically look at this area. There will be finding in the temporal lobe of the brain. This is very, very important point for the diagnosis. In case of rabies, Negri bodies are formed in hippocampus and Purkinje, okay, neurons and Purkinje fiber. So just remember, Negri bodies are formed in hippocampus area, and these Negri bodies are diagnosed after the death of the patient because we need to do brain biopsy to diagnose them. Now, the last part of CNS infection is brain abscess or cerebral abscess. So let's talk a little bit about it. Now, cerebral abscess occur as a result of hematogenous dissemination or direct spread from the contiguous foci or direct implantation of the microorganism inside the brain. These are the same type of discussion which we did in the beginning of this topic. Remember, there are 4 different ways by which microorganisms enter into the brain. So this is the brain abscess. That means microorganisms or mainly bacteria are reaching inside the cerebrum or inside the brain, and these are the way. The common causative agents of brain abscess are staphylococci, streptococci, okay, and many of the time they are mixed organism, both aerobe as well as anaerobe. Now, there are certain predisposing conditions or factors which are responsible for brain abscess, like acute bacterial endocarditis. We have studied this topic in CNS cardiovascular system pathology. Endocarditis means there is vegetation formation on the heart valve, and those vegetations are carrying bacteria inside it. So if this vegetation reaches the brain, easily brain abscess can occur. Cyanotic heart disease, especially right to left shunt, or another very important cause of brain abscess. Now, you may be wondering why brain abscess commonly occurs in cyanotic heart disease or right to left shunt. So let me explain this. Now, what happened in right to left shunt? Okay? Blood is directly going to the left side of the heart from the right side of the heart. Means lungs are bypassed. Okay? Blood is not flowing towards the lung that much. It is directly going to the left side of the heart. That's why we call it right to left shunt. Now, what is the function of the lung regarding immunological function? Means there are alveolar macrophages present inside the lung, so they will filter the blood. Meaning is, if any microorganisms or bacteria are present in that blood, that will be filtered out in the lung. But that function is lost now because blood is not going towards the lung. That means microorganism can directly go into the left side of the heart, and from there any organ of the body. If it reaches the brain abscess can occur. So never forget this explanation. Another predisposing condition may be chronic pulmonary abscess. This is because of metastasis of those abscesses. Mastoiditis means inflammation of mastoid process or mastoid antrum. It's a part of middle ear. Paranasal sinusitis and acute otitis media. All of these are predisposing risk factor. Open fracture of the skull, microorganism can directly enter inside. And previous neurosurgery. Who knows, during neurosurgery, microorganisms are implanted inside. This is very rare to occur, but sometimes it may happen as a result of use of unsterilized equipments. Now, which part of the brain are commonly affected? Frontal lobe, parietal lobe, and cerebellum are more commonly affected than other parts of the brain. But frankly speaking, any part of the brain can be affected. The best way to diagnose brain abscess is by CT scan. Okay, if CT scan is not that confirmatory, you can go for MRI as well. And in CT or MRI, a ring enhancing lesion is seen. To see this ring enhancing lesion, we need to go for contrast enhanced study. That means you have to give contrast material first inside the blood, and then CT scan should be taken. Now, what are the clinical feature or clinical manifestations of brain abscess? Brain abscess is a space occupying lesion inside the brain. That means it will definitely lead to increased intracranial pressure. So there are certain signs of increased intracranial pressure, which are headache, vomiting. This vomiting is usually a projectile type of vomiting. Blurring of the vision is not very clear, or sometimes even the double vision may be there. And one very important feature known as Cushing striae is usually present in raised ICP. And those Cushing striae means the three things together: hypertension, bradycardia, and irregular respiration. Never forget this. Hypertension or increased blood pressure, bradycardia or decreased pulse rate, and irregular respiration. If we examine the fundus, okay, or retina of that patient, papilledema is very commonly seen. Papilledema means edema formation or swelling of the optic disc. There are certain focal neurological deficit which is very common in brain abscess. Okay, it depends which area of the brain is affected and how big is the abscess. Okay, there may be involvement of the cranial nerve, okay, involvement of different nerves, or some descending or ascending tract, which results in different neurological deficit. Now, how it is treated? Okay, remember this is caused by infection, so antibiotics is very much necessary, but surgery also play a big role. Okay, now at the end, please go through these questions and solve them confidently. Good evening, everyone. So, I'm going to talk about cardiovascular accident or stroke in this class. This class belongs to pathology, a systemic pathology inside the central nervous system pathology. Now, what is the definition or the meaning of cerebrovascular accident or stroke? Stroke or CVA or cerebrovascular accident is a sudden onset neurological deficit which is caused by decreased blood flow to a particular part of the brain. So remember, this is a sudden onset neurological deficit. Neurological deficit means some neurological sign will be there in the patient. Okay, and this occurs because of decreased blood flow to one particular area or part of the brain. And two main causes are responsible for this: ischemia, which leads to infarction of a part of the brain, or hemorrhage, which occurs because of rupture of blood vessel. Now, this CVA or stroke is the third most frequent cause of death in industrialized country, but even in developing country, this is very common these days. This is a leading cause of serious disability all over the world. What do you mean by that? Disability means the person has developed paralysis, so that the person cannot move the body or move the limbs. And stroke is a very common cause of that. Now, why this cerebrovascular accident or stroke occurs? Because of certain risk factor, and these risk factors are similar to coronary artery disease. If these risk factors are present in the patient, then the same patient may be having coronary artery disease or myocardial infarction as well as stroke. Now, you have already done this before, so let's list what are the risk factors for CVA or stroke. If this question is asked, don't get confused. This is a very easy answer, but trust me, this is one of the most commonly asked questions to the students. These risk factors are divided into major, and additional factors. Now see here, what are the major risk factors of a stroke? They are further divided into non-modifiable and potentially controllable risk factors. Non-modifiable means we cannot do anything to modify them, like increasing age or older age. Stroke is more common in older age. Male gender, they are more common in male patient, of course, but even in female gender, after post-menopausal age, stroke can occur. Family history, very important risk factor. So it runs in the family, and certain genetic disease or genetic abnormalities. Now, those four potentially controllable risk factors are hyperlipidemia or hypercholesterolemia, hypertension, cigarette smoking, and diabetes. These are all controllable risk factors. They can either be omitted or they can be controlled with the help of medicine. If more than one of these risk factors are present in the patient, there is high chance of death, either because of myocardial infarction or because of the stroke. Now, what are the other additional factors along with them? Obesity. Obesity. What's the definition of obesity? If body mass index or BMI is more than 30. And obesity is a very important risk factor these days because more and more people are getting obese. Physical inactivity is stressful or type A personality. This is called neurotic type of personality or type A personality or stressful personality. The person takes everything very seriously. The person would be nervous in most of the event. Post-menopausal estrogen deficiency, I just now mentioned about that. After the menopause, even the lady becomes predisposed for the development of stroke, and alcohol consumption. Okay, these all are additional risk factors. Now, what are the types of stroke or cerebrovascular accident? There are mainly three types: TIA or transient ischemic attack, infarction, and hemorrhage. Now, transient ischemic attack or TIA means, okay, this is a type of stroke or CVA where symptoms last less than 24 hours. Means everything comes back to normal within 24 hours. So this is a reversible type of condition. And this occurs because of small thrombi or atheroemboli, which is blocking a very small blood vessel inside the brain, and they clear by themselves. Some of the good example of TIA, okay, are a person coming to the hospital with sudden onset blindness. The person cannot see anything. Okay, we take a very good history. We admit the patient in the hospital. We send many different investigation, isn't it? But within 24 hours, for everybody's surprise, the patient tells the doctor, "Doctor, I can see again." Okay, this is a very good example of TIA. Next type is infarction or cerebral infarction, and this is the most common type of stroke. Almost 85% of all stroke cases belong to cerebral infarction. Now, what is the cause of infarction? This is mainly caused by thrombosis of cerebral artery, and this thrombosis, okay, is associated with atherosclerosis. Now, I'm mixing these two things together here, okay, but it is very easy to understand. In the beginning, because of those risk factors, there is atheroma or atherosclerosis formation. This atherosclerotic plaque may rupture, and on the surface of that ruptured plaque, thrombus will form. That's why thrombosis is written here. Now, out of three important cerebral arteries of our brain, can you list what are those three important cerebral arteries? In the last class, I talked about them: anterior cerebral, middle cerebral, and posterior cerebral. Among them, middle cerebral artery is most commonly affected in case of cerebral infarction. After thrombosis, embolism is the second most common cause of infarction, and these emboli, they mainly originated from the heart. That's why it is written as cardiogenic emboli. Any heart disease in the patient may result in cardiogenic embolism, especially mitral valve disease or left atrial disorders or even left ventricular disease. Apart from them, some small vessel disease like arteriosclerosis and amyloid angiopathy can also result in cerebral infarction. Sometimes even a connective tissue disorder can result in that. Now, third types of cerebrovascular accident or stroke is hemorrhage, and this is around 15% of all stroke cases, and this hemorrhage can occur in two different areas: intracerebral hemorrhage and subarachnoid hemorrhage. Some of the textbook, subarachnoid hemorrhage is mentioned as a separate entity. It may not be a part of cerebrovascular accident, but in many other, it is included as a part. So you can safely write this as a part of stroke. Now, okay, let's talk a little bit about infarction. So see there, again the same things, many of the things have been repeated. The most common cause of cerebral infarction is thrombotic occlusion, and it is associated with atherosclerosis. Second important one is embolic occlusion, and these emboli are mainly originated from the heart, okay, and less frequently they are originated from the atheroemboli. And another common cause of infarction is small vessel disease, which may be related to hypertension, okay, and hypertension is causing high lean type of arterial sclerosis, which may make the blood vessel narrower. This small vessel disease may lead to lacunar type of infarct, and this lacunar infarct, lacuna, may be defined as small subcortical infarct, which are usually less than 15 millimeter in diameter, and they are mainly present in the territory of the deep penetrating arteries which arise from circle of Willis. If you remember, in the last discussion, I clearly told you from the circle of Willis, two different sets of arteries are originated: cortical or superficial branches and penetrating or deep branches. Now, if these deep or penetrating arteries are blocked because of this mechanism, then it is called lacunar infarct. One of the important manifestation of this lacunar infarct is internal capsule lesion. Now, what are the clinical manifestation of cerebral infarction? Okay, and the answer is it depends on which artery is affected. Okay, so see there, if anterior cerebral artery is blocked, then the area which is supplied by that artery is affected, isn't it? But your discussion doesn't end here. You should know which areas of the brain is mainly supplied by anterior cerebral artery. Okay, then only you can answer this. So there is weakness and sensory loss in contralateral leg in case of anterior cerebral artery. Now, how can I remember that? Okay, let's go back, okay, to the area which is again supplied by anterior cerebral artery. Please open my last slide or discussion, or you can open any anatomy book or even the physiology book and see which areas of our brain is supplied by anterior cerebral artery. You will get your answer there. Okay, mainly the medial part of the cerebral hemisphere, as well as a small strip in the superolateral aspect is supplied by anterior cerebral artery, and there lies the leg area of our brain. Middle cerebral artery, okay, if it is blocked, then there occurs contralateral hemiplegia. Contralateral means opposite half of the body. For example, if right side of the brain is affected, then left half of the body will be paralyzed. This is called contralateral hemiplegia, and it mainly affects face and arm. There is contralateral sensory loss also, and there is aphasia if a dominant hemisphere is affected. Aphasia means loss of speech. The person cannot speak anything, okay, especially the motor one. Now, what do you mean by dominant hemisphere? It depends, okay, whether you are right-handed person or left-handed person. In this world, majority of the people are right-handed. So, if I am right-handed person, the dominant hemisphere or cerebral hemisphere in me is the left cerebral hemisphere. It's opposite one, isn't it? Because the opposite hemisphere will control our limbs. So, if left cerebral hemisphere is ischemic or it develops infarction, then the person will develop aphasia. If posterior cerebral artery or PCA is blocked, then there would be contralateral hemianopia, or there would be total cortical blindness if bilateral involvement is there. Now, contralateral means opposite side again. Hemianopia, okay, hemianopia means there will be vision loss or visual field loss in the same aspect of both eye. Okay, and cortical blindness means affection of visual cortex. I mean the person cannot see anything now, or the better description would be the person cannot interpret what the person is seeing, and without interpretation the person cannot say what object is that. Another manifestation of cerebral infarction is dementia, and this dementia means loss of memory. This dementia is very common if there is recurrent infarct or small vessel disease over a long time. Now, let's talk about what are the common causes of intracerebral hemorrhage. Now, this intracerebral hemorrhage is not that very common type of stroke. Only 15% of the stroke cases are because of hemorrhage. And the common causes of intracerebral or intraparenchymal hemorrhage are hypertension, which is the most common one. This is called systemic hypertension or raise in blood pressure. Okay? It mainly involves basal ganglia, cerebellum, and pons. This basal ganglia, especially putamen, is very commonly affected site. Other causes apart from hypertension are vascular malformations like AB malformation, cerebral amyloid angiopathy. This is amyloid deposition in the cerebral blood vessel, neoplasm or brain tumor, vasculitis or connective tissue disorder, abnormal hemostasis. Okay, abnormal hemostasis means there is a certain lack of the clotting or coagulation factor, which may result in hemorrhage in different part of the body. Hematological malignancies like leukemia, where there is thrombocytopenia, as well as infection, where there is a high chance of disseminated intravascular coagulation. Now, what are the common symptoms in case of hemorrhagic stroke? There would be severe headache in the patient, and along with that severe headache, the patient usually lose consciousness level. By the time this patient is brought to the hospital, the patient is in deep coma usually, and the person may develop seizure as well. Along with that, the patient may vomit also. So these are the common symptoms of hemorrhagic stroke. Now look at this picture here. Okay, there is a big blood clot. This blood clot is because of hemorrhagic stroke. Another type of hemorrhage which occurs inside our cranial cavity, okay, is epidural hemorrhage. Before I go into the discussion of epidural hemorrhage, let me list what type of hemorrhage can occur inside the cranial cavity. Okay, let's go layer by layer. The outermost one is extradural or epidural hemorrhage. Same term, epidural or extradural. After that, subdural hemorrhage. Okay, I'm going one layer inside. After that, subarachnoid hemorrhage. Okay, after that, it is intraparenchymal or intracerebral hemorrhage, and the innermost one is intraventricular hemorrhage. Okay, intraventricular. Actually, these ventricles are the part of our brain itself. So these are the different type of hemorrhage which occur inside the cranial cavity. But right now, let us focus on what is epidural hemorrhage. This epidural hemorrhage occurs in epidural space. Okay, this is a potential space actually. This is not a real space there. It almost always occurs because of trauma, and this trauma is a severe type of trauma which results in skull fracture. Okay? Especially this trauma or fracture of the skull occurs in temporal, okay, bone of our skull. Now, what are the common causes of this injury or trauma? Okay, one of the important example I like to give here is during cricket play. Okay, that hard cricket ball, when it hit flush on the temple area, okay, then there is high chance of epidural hemorrhage occurring in that patient, and that patient may die suddenly. So many cases, okay, we come across. Some of the cricketers die right in the field. Some may die a bit later on. This is a perfect example of epidural hemorrhage. Now, which artery is ruptured there? The name is middle meningeal artery. Don't forget that. Middle meningeal artery, which is ruptured because of trauma. Because this is arterial bleeding, the bleeding can occur quite briskly, and over a short period of time, it can lead to the formation of a big blood clot there, which will cause raise in intracranial pressure and a lot of clinical features. If this is not treated in time, it can also lead to cerebral herniation, and usually the subfalcine type of herniation is commonly seen. Lucid interval is a very common manifestation in case of epidural hemorrhage. Now, what do you mean by this lucid interval? In case of epidural hemorrhage, okay, because of the injury, the brain, it just gets shaken, okay, or we can understand like this: there is concussion injury to the brain. Concussion means shaking of the brain, okay. Because of this, the person may feel dizzy, or the person may lose consciousness for a very brief moment, okay. After that, the person will regain the consciousness level, and sometimes the patient may even continue to play or continue to bat. But remember, because of the rupture of the blood vessel, bleeding is continuously occurring. After few minutes, okay, it may be 15 minutes, it may be 20 or even 30 minutes, the blood clot reaches to a maximum level, and then the person loses consciousness. The gap or interval between these two episodes of unconsciousness is called lucid interval. Okay, this lucid interval is also known as talk and die syndrome. Now see there, look at this picture here. This is the area where there is severe injury resulting in epidural hematoma. Now, what is the treatment of this particular condition? Okay, though we don't talk about treatment in pathological lecture, but still this is very important, condition. That's why I'm mentioning it here. As soon as you suspect or diagnose this condition, refer the patient or take the patient immediately to the neurosurgical unit, and this blood clot has to be evacuated, okay, and that blood vessel should be ligated. Then only the patient can survive, otherwise patient will die. Now, what is the subfalcine herniation? See here, this is called subfalcine herniation. It's right here. The other types of herniation which we discussed in the last class, this is transtentorial herniation, there is tonsillar herniation, and if the whole brain stem is herniated downwards, we call it central herniation. Now, after epidural hemorrhage, let's talk about subdural hemorrhage. The name itself suggests it occurs in subdural space. It is also because of trauma, and in comparison to the epidural hemorrhage, the subdural hemorrhage is considered a bit less severe. But please don't get mistaken here. It can also lead to death in the patient. Okay, the death can occur slowly in comparison to the epidural hemorrhage, which can lead to sudden and fast death. Now, one other difference is it is caused by rupture of bridging vein, whereas in epidural hemorrhage, that is caused by rupture of middle meningeal artery. Now, certain predisposing conditions for subdural hemorrhage are atrophy of the brain and abnormal hemostasis in the patient. This atrophy of the brain may cause some strain to those bridging vein, and they may just start to bleed. Some of the clinical feature would be headache, drowsiness or loss of consciousness, focal neurological deficit, as well as dementia. These are some of the clinical features. Okay, and treatment is evacuation of the clot. This is very, very common in alcoholic patient. If somebody is chronic alcoholic, then they may suffer repeated subdural hemorrhage. Now, one common question we like to ask is, what are the differences between epidural or extradural hemorrhage and subdural hemorrhage? This slide is trying to explain the same. Now see here, okay? On this side, there is epidural or extradural hemorrhage. Look at the shape of the blood clot. It is convex in shape. Okay, we call it convex shape because this bleeding is very brisk. It can quickly develop the collection of good amount of blood clot, and it will press large part of the brain inwards. Okay, whereas subdural hemorrhage occurs because of rupture of the bridging vein, so blood collect very slowly. Now, what is subarachnoid hemorrhage and what are the common causes? Subarachnoid hemorrhage occur in subarachnoid space inside the cranial cavity, and the most frequent cause is rupture of berry aneurysm. Now, these berry aneurysms are the congenital aneurysm which are already there. Okay, somehow if they are ruptured, then there is subarachnoid hemorrhage. Apart from berry aneurysm, other less frequent causes are extension of an intracerebral or subdural hematoma. Extension means the bleeding is coming in the subarachnoid space from some other area. Rupture of vascular malformation, trauma, okay, or head injury, abnormal hemostasis like thrombocytopenia or DIC, or even leukemia or plastic anemia, as well as brain tumor. So there are other causes of subarachnoid hemorrhage. Subarachnoid hemorrhage has very typical clinical feature. This patient complains of sudden headache, which is the most severe one. So this headache we label as thunderclap or thunderbolt headache. Along with that, the patient also have neck rigidity, okay, or stiffness of the neck. This is because of irritation of those meninges by the blood. Neurological deficit is quite common, and the very important feature would be loss of consciousness. In the beginning, drowsiness, stupor, or coma. Stupor means somewhat a middle state between drowsiness and coma. Now, let's talk a little bit about berry aneurysms because they are the most common cause of subarachnoid hemorrhage. Now, these berry aneurysms are very thin-walled, saccular outpouching, okay, from circle of Willis. Thin-walled, saccular outpouching from circle of Willis, and they mainly consist of intima and adventitia only. Now remember that there are three layers in any blood vessels except capillary. Okay, both vein as well as artery has three layers. Innermost layer is called tunica intima, the middle one tunica media, and the outer one tunica adventitia. But in this case, tunica media is absent. That's why these berry aneurysms are very weak structure. They can rupture very easily. Most frequent site are, of course, circle of Willis, but where in circle of Willis? This is the branching point in circle of Willis. Now, branching point means from this point, different blood vessels are going away from each other. Okay, these are the branching area. Now, let's look at this branching point immediately. See here. Okay, this is the diagram of circle of Willis, and these are the branching areas. See here. Okay, one artery. This is called anterior communicating artery, and this is the anterior cerebral artery. So this is the branching area here. Here is another branching point. Here is another one. Here is another one. So it is quite common in this branching area. Okay. Now, what's the reason why berry aneurysms are there? Okay. This is present as a congenital way, and there is a congenital focal weakness of the artery, which may not be identifiable at the time of birth or even during childhood period. This type of patient, they present suddenly with subarachnoid hemorrhage, and during surgery we found out, oh, this is the cause, this is caused by berry aneurysm. Some associated disorders of berry aneurysms are Marfan syndrome, Ehlers-Danlos syndrome, both of them are called connective tissue disorders, and adult polycystic kidney disease. These are the association of berry aneurysm, so that we need to take a good history we need to do good examination of the patient, and we try to diagnose this condition, whether they are present in the same patient or not. Now, why it gets ruptured, isn't it? That's another question which may come in your mind. And the cause of the rupture is sudden increase in blood pressure. Now, what are the causes of sudden increase in blood pressure in us? Any stressful situation, okay? If you get angry by something, then your blood pressure will shoot up. Even if you're being extremely happy, and if you laugh suddenly, if you are excited about something, then also the blood pressure may go up. Okay, but that blood pressure should come down after a period of time. Okay, and it should not do any damage in the body. But if circle of Willis is having berry aneurysm, then the sudden increase in blood pressure may be too much for that weak aneurysm, and then it may get ruptured. Now, prognosis after the rupture in case of berry aneurysm are 1/3 of the patient die, 1/3 of them recover, and 1/3 of them rebleed again even after the surgery. Okay, so 1/3 means 33% around. Now, I have included a small topic here known as neural tube defect. Okay, these neural tube defects are not the part of stroke or cerebrovascular accident. Please remember this. Okay, these are completely different type of things, but these are also important one, and a lot of questions will be asked from here. So let's talk a little bit about them. These are the most common developmental central nervous system abnormalities in the patient. Okay, they are called CNS abnormalities, which may manifest at the time of birth. They may result from defective closure of the neural tube, okay, and folic acid deficiency is mainly involved in pathogenesis here. Very important question in the exam. Folic acid deficiency in the mother, okay, during pregnancy can result in neural tube defect development in the baby. Now, some of the examples of neural tube defects are anencephaly, encephalocele, okay, encephalocele, and some of the other neural tube defects of the spinal cord, like spina bifida occulta, meningocele, meningomyelocele, myelocele itself. Okay, so let's talk one after other. What is anencephaly? Anencephaly means absent of the brain. The brain is not developed properly. Along with that, even the skull bones are absent. And this occurs mainly because of malformation of the anterior end of neural tube. Okay, during the development of the baby, during the development of neural tube, there is certain malformation so that the anterior neuropore doesn't get closed, and as a result of this, anencephaly develops. This is incompatible with life, and these babies die soon after birth. Even if they survive, they may survive for few hours, or some, in rare situation, few days. Now, encephalocele is herniation of the brain. This is the diverticulum of malformed CNS tissue extending through a defect in the cranium. Okay, and it is mostly occurring in occipital region or in the posterior cranial fossa. Means from the back side of the head, okay, a piece of brain tissue is exposed outside. This is called encephalocele. Now look at this picture here for some time. See here, look at this baby first. Okay. This is occurring at the vertebra. This is also occurring at the vertebra. Okay, only the places are different. So this is a type of neural tube defect which is occurring from the spinal cord. See here, this is another one. Okay, look at the deformity of the leg and foot as well. So this is a schematic diagram. Okay, see here, this spinal cord is herniated outside, and it is covered by meninges. So this is called meningomyelocele. Meningo is the term for meninges. Myelo is the term for spinal cord. and seal is a cyst formation there. That cyst formation is because of herniation of the content outside, because of the defect in the vertebra. Meningocele, spinal cord is at its own place. It has not gone outside. Only the meninges is going outside as a bulge. So meningocele. Now, okay, so the important pictures are already highlighted. So same things are repeated here again. Spina bifida occulta. Occulta means hidden. There is only bony defect of the vertebral arch, but nothing wrong with the spinal cord. It has not gone outside, or even the meninges have not gone outside. But when I feel at that particular site, I can feel that bony defect there. And some of the babies, there is a tuft of hair present in that area. So this is known as spina bifida occulta. Occulta means hidden. The second variety is meningocele. Through the bony defect, there is outpouching of meninges. So when we examine the baby, there is a cyst or a bulge, okay, present on the back. Usually this bulge is present on the lower back, meningocele. Meningomyelocele, along with the bulging of the meninges, there is bulging of the spinal cord and spinal root also. So this is definitely more serious condition than meningocele. Another is myelocele. Okay, there is complete exposure of the spinal cord. It is not covered by the meninges. So this is called myelocele. Now, what is the danger of these neural tube defect? Okay. They may cause serious damage in the baby, like paraplegia and urinary incontinence right from the birth. Now, what is paraplegia? Para means lower limb. Plegia means paralysis. So both lower limbs are paralyzed as a result of damage to the spinal cord. So the baby cannot walk. The baby will be paralyzed from the time of birth or after some time after birth. Urinary bladder and rectum are controlled by spinal cord. So if spinal cord is badly damaged, the baby cannot hold urine and stool, resulting in incontinence. Another important problem of this type of bulging and outpouching is recurrent infection in the central nervous system, like recurrent meningitis, which is quite common. Okay, so after going through all those different things, I've compiled some of the questions for you. So please go through them and try to solve them. Hello everyone, good evening. So right now I'm going to talk about central nervous system tumors. This is a very short and concise discussion regarding brain tumor or central nervous system tumors. So if you want to know in detail, I suggest you to go to any good or consult any good pathology book and study in detail. Okay, but the information which I'm providing here would be enough for the undergraduate students. Now, some important points to start with. The primary brain tumors are more common than secondary tumors. Now, what is the difference between primary tumor and secondary tumor? I'm sure every student knows that already. Primary tumor means the tumor which has developed in that anatomical site. It has not come from any other source or area. And secondary tumors means this is usually metastatic tumor. From some other site, the tumor has gone there or come there. In case of brain, primary brain tumor are more common than the secondary one. Related to the incidence, tumors of the central nervous system account for 20% of all cancers in childhood. In other words, these are the second most common cancers in children. What is the first one? Anyone? Very good. Leukemia, especially acute lymphoblastic leukemia, ALL, is the most common childhood cancer, followed by brain tumor and then lymphoma. 70% of childhood CNS tumor that arise in the posterior cranial fossa. This is an important, epidemiological point in children, whereas in adult they are common in the cerebral hemisphere above the tentorium cerebelli. This is known as supratentorial area or supratentorial compartment. Okay, and below is infratentorial compartment. So posterior cranial fossa is infratentorial compartment. So in children, commonly brain tumor occur in infratentorial compartment, whereas in adult it mainly occurs in supratentorial compartment. Let's go to the classification of central nervous system tumors. There are 4 major types of brain tumor. Those are glioma, neuronal tumor, pinnet, which is known as primitive neuroectodermal tumor, and meningioma. So among the glioma, there arises from the glial cells like astrocytoma, okay, astrocytoma, which are originated from the astrocyte, oligodendroglioma, which originate from the oligodendroglial cells or oligodendrocyte, and ependymoma, they originate from the ependymal cells. Neuronal tumors, there are ganglion cell tumors, pinnet, medulloblastoma, and meningioma. These are arises from the where? Of course, from the meninges, isn't it? These are the main classification. Now, the tumors which arises from the brain, spinal cord, they have got some unique features. Okay, there are so many points for this uniqueness of central nervous system tumor. The important point is the distinction between the benign and malignant lesion is very less evident in the CNS than in other organs. Okay, so let me explain this in an easy way. Whatever tumor is there inside the brain, whether it is benign or malignant, we should take it very seriously. Of course, malignant tumor everyone will take seriously, but even the benign tumor, okay, we should take it just like a malignant one. Why? What's the reason? Okay, I want to compare the tumor inside the brain with tumor on the surface of the forearm. If a benign tumor occurs on the surface of the forearm, we are not that concerned. Okay, probably we can ignore it, but inside the brain we can never do that. Why? Because inside the cranial cavity there is no extra space. Even slight growth in any mass can give rise to severe rise in intracranial pressure, which can kill the person. Okay, so this is a very, very important point. The second reason we can give some glial tumors which are benign histologically, but they can infiltrate the large areas of the brain and they can behave like a malignant tumor. Another one, the surgical resection without damaging the function of the brain is very difficult, even if this is a benign tumor. Okay, so the large areas of the brain can be damaged during surgery even in benign tumor. So because of this, the distinction between benign and malignant lesion is less evident in the brain tumor. Now, what is the pattern of spread of primary CNS tumor? It may also differ from other tumors here. Even the highly malignant tumor in the brain doesn't go out of the central nervous system. It may metastasize in the local area. The CSF flow or cerebrospinal fluid flow can disseminate tumor cells along wide areas of the brain and spinal cord, both in well-differentiated as well as in anaplastic tumor. Now, what is the meaning of well-differentiated and anaplastic tumor? Okay, you already know it. Well-differentiated tumor means even if that tumor is malignant, the cells look like a bit of benign type, okay, or more like a normal cells. But anaplastic means highly malignant cell. There is no similarity between malignant cell and the normal cells, or the benign tumor cells. Now, what are the common clinical manifestation of brain tumor? What happens to the person? Whatever types of CNS tumors are there, these may be the clinical features. Headache. This headache is a serious type of headache, okay, and it is more common in the morning time. In the morning time, there is slightly rise in intracranial pressure, so headache would be more, and along with the headache there would be vomiting. This is projectile type of vomiting. Seizures are quite common, especially if the tumor are originating from the cerebral cortex, or in other words, if they are supratentorial tumor. Mental changes like memory loss, decreased concentration or focus, and loss of reasoning, all of these are very common again in supratentorial tumors. Focal neurological deficit or symptom which are related to the involvement of specific brain regions are quite commonly seen. I'll give you an example here. If a tumor is originated from the frontal lobe of the brain, what will happen to the person? To answer this question, you need to know what are the functions of frontal lobe of the brain, what are the functions of parietal lobe, temporal lobe, occipital lobe. Then the answer is very easy. So frontal lobe is mainly concerned with cognitive function, okay, cognition, that is frontal lobe function. Even the Broca's area is present in the frontal lobe, isn't it? Even the primary motor cortex is present in the frontal lobe. So these are the different points. I'm just telling you how to answer the question. Another important point, there are lots of clinical features which will arise as a result of increased intracranial pressure. Now, why raised intracranial pressure would be there? The reason is because of presence of a space occupying mass within the cranial cavity. We are talking about brain tumor now. As a result of blockage of shear flow, because of the mass which is blocking the shear flow, which is more common in infratentorial tumor, and edema around the tumor, also known as peritumoral edema, because of the pressure. So these all can lead to high intracranial pressure, which can lead to herniation of the brain and can lead to death. Now let's talk a bit about individual tumors. What happens in astrocytoma, what happens in pinnet, and what happens in medulloblastoma. Now astrocytoma, they originate from astrocyte, and these astrocytes are called glial cells. And there are some common histological finding. They exhibit fibrillary background. This is an important histological finding, and they are positive for glial fibrillary acidic protein. Okay, glial fibrillary acidic protein. This type of questions may be asked in MCQ exams, and they usually grow very diffusely. Now, among the fibrillary astrocytoma, okay, grading is very important because it is the important point in prognosis and treatment as well. So, according to this, okay, 4 grades are there, and these grades are based on nuclear atypia or pleomorphism. Pleomorphism means what is the appearance of nucleus in between the cells. Mitosis, necrosis, and vascular endothelial hyperplasia. Based on these 4 features, the grades are divided into 4 types. Grade 1 to 2 are well differentiated. Grade 3 is anaplastic, and grade 4 is the most malignant out of all, which is known as glioblastoma multiforme. Now, let's know a little bit about what is this glioblastoma multiforme. This is the most common central nervous system primary malignancy. Now look at this point here. This is the most malignant central nervous system tumor, but this is the most common among all. That shows the prognosis of central nervous system tumor. Histology, there is marked nuclear atypia, presence of mitosis, necrosis, and vascular endothelial hyperplasia. All 4 features are very commonly seen. Atypia means it doesn't match between the cells. Prognosis is very, very poor. Even after surgery with chemotherapy and radiotherapy, the mean length of survival is only 8 to 10 months after the diagnosis. Only 8 to 10 months. Now look at this picture here. Okay, dear students, I want to mention one thing here. Right now, I am sending you only the audio form because video is a bit long. It is not possible to send in WeChat. But after a certain time, I'll upload this video form in YouTube. Okay, so please follow my YouTube channels. I will let you know when I upload these things. Now look at this picture. There is a huge rounded mass, and this is a tumor. This tumor is causing deformity in that area of the brain, and this area is expanded. Okay, so gyri are elevated and sulci are flat. This is a real pathological specimen of which is showing expanded white matter and very thick corpus callosum. This is thick corpus callosum. Now this picture, this is a CT scan or computerized tomographic scan of a brain, and this is a tumor here. This is a tumor. This CT scan is, there are 2 types of CT scan of the brain. One is a plain CT scan, another is contrast enhanced CT scan. So this is a contrast enhanced CT scan. So contrast material is given and CT is taken. Okay, so it almost looks like a ring enhancing lesion here. Ring enhancing lesion, and this is the edema, peritumoral edema, which has occurred around the tumor. Another one is real pathological specimen. This is glioblastoma multiforme, which is a necrotic lesion. Necrotic is black area, you can see here. Hemorrhagic is red area. Okay, and this is infiltrating in the different parts of the brain. This is highly malignant central nervous system tumor. Prognosis is very, very poor. Now let's talk a bit about meningioma. Meningioma is a benign tumor of the brain. It originates from meningothelial cells of the arachnoid matter. So that is the origin. Arachnoid matter is a layer of meninges. This is a tumor of adulthood, and women are more commonly affected than the men. It is quite rare in children. Related to the gross and microscopic feature of meningioma, okay, they are attached to the dura matter and they possess the underlying brain without invasion. Okay, because they are benign tumors, so they do not invade the underlying brain. Related to the microscopic feature, these cells are spindle-shaped cells. This is just the shape of the cell. These cells are arranged in holes or fascicles. Holes or fascicles means they're rounded structure. Okay, just like the layers of the onion. Okay, different holes are there. And one very important finding is the Samoma bodies are very frequently present there. This is called Samoma body. P is silent here. Okay. Now, what do you mean by this? The Samoma bodies are the concentric type of calcification which are present in the tumor. This calcification, okay, is a specific pattern of calcification. And this calcification are also seen in other types of tumor like serous adenocarcinoma of ovary, okay, is another very common, and papillary cell carcinoma of the thyroid. Now, meningioma may develop at any meningeal site, okay, any meningeal site. Wherever the meninges are present, these tumors are there, and they are most frequent on the dural convexity. Because of the benign tumor, they have a good prognosis, and if they are a bit in difficult type of area, then it is difficult to completely resect them. But nevertheless, okay, because of the advancement in neurosurgery, they can be well treated. Now look at the picture here. This is a real pathological specimen. Okay, you can see in this area there is a meningioma, and these are the histological appearance of meningioma. They have the whole appearance, and the psammoma bodies are seen. These are the psammoma bodies. See, these are the calcification. Okay, calcification. Now, the third type of tumors are PNET, primitive neuroectodermal tumors. They are highly malignant, and the source of origin is a neural crest cells. Okay, they are highly undifferentiated or poorly differentiated tumors. They are variably named according to the location, and the most frequent PNETs are medulloblastoma and retinoblastoma. Now, retinoblastoma, it occurs in the retina. Retina is a part of eyeball, so we are not going to talk about that now. Medulloblastoma occurs in the brain, especially in posterior fossa of the brain. Now let's know a little bit about it. Before I go to the medulloblastoma, let's talk about some of the common features of PNETs. They develop mainly in children, and the histology is quite important here. They are blue, small, round cell tumor with pseudo rosette. This is very, very important finding in histology. Blue, small, round cell tumor with pseudo rosette formation, and they are highly aggressive, but they respond well to radiation therapy. So treatment is a real possibility. Medulloblastoma arises in the cerebellar vermis. Okay, vermis is a midline structure of cerebellum, so it mainly originates from the vermis area. It grows very rapidly and is spread through cerebrospinal fluid. But one very satisfactory point is resection and radiation therapy is possible, and it allows 5-year survival rate near to 75%. So 75% of the children can survive more than 5 years. That means the cure rate is more than 75%. Now, what are the common clinical features of medulloblastoma? Remember, first, where is the tumor usually located? In the posterior cranial fossa. As a result of this, it may quickly block the flow of CSF around the fourth ventricle area. So there is increased intracranial pressure, and many signs and symptoms are secondary to that. The child develops repeated episodes of vomiting and early morning headache. Is a feature of raised ICP. Okay, and because of the location of the tumor, the child also have gait abnormality because cerebellar function is abnormal. The child also suffer from frequent fall. Double vision or diplopia is a feature of raised ICP. Papilledema, okay, this is edema or bulging of the optic disc. This is also a feature of raised ICP. And paralysis of sixth cranial nerve. This is known as false localizing sign in case of raised ICP. And can you tell me which muscle is supplied by sixth cranial nerve? Which muscle? That is extraocular muscle. What is the name? Lateral rectus. And what is the function of that lateral rectus? Abduction of the eyeball. Okay, so if that nerve is gone, that muscle is paralyzed. As a result of this, the person will have diplopia. This picture is telling us so many important points here. Okay, here CT scan showing a contrast enhancing midline lesion in the posterior fossa. This is the one. This is the huge lesion in the posterior fossa, and if you look very carefully, see this. Okay, this is lateral ventricle. This is also lateral ventricle, lateral ventricle. This is third ventricle. All of these are dilated. That means already hydrocephalus is very common here, and it is already occurring in this patient. Sagittal section of the brain showing medulloblastoma destroying the superior midline cerebellum. This is cerebellum. This whole structure is cerebellum, and here is the destruction. Microscopic appearance of medulloblastoma is seen in this. These are small blue rounded cell. Small blue rounded cell. Okay, so at the end, answer